Shawn. Joined the ecosystem or the movement probably mid-18 after an epiphany, I think CEO over 18 different hospitals, other group roll-ups, division roll-ups, company-wide, and the like. A lot of turnarounds, and got home mid-18. One day, my wife said, you need to make a change because you're not bringing this stuff home anymore. In terms of what we're doing here in the space at WoundCentrics and what we bring from a care side, and also, learning what the hospitals do, and our slogan, is be what the hospital's not. And so feel pretty good about that. The wound care space is something that is sometimes highly overlooked. Many patients go unrecognized until it's too late. And joining the group with WoundCentrics, it was important that we had the same like-mindedness. And the man that's standing beside me is that guy for sure. Dr. Gitterle, I think he started out as an ER doc in internal medicine, and he's also our chief medical officer. Not only does he direct the strategy from wound care protocols and the like, but he still sees patients. And we also have educational. We have a WoundCentrics University, which Dr. Gitterle also runs, and he pilots that as well. I'm going to go over a few of the background slides, and then when Dr. Gitterle takes over the presentation, he'll say a little bit more about himself, because there's a whole lot more than I did mention. And also the real meat of the presentation is really what Dr. Gitterle is going to be talking about. Thank you. So in the wound care space, the major disease we see is PAD, and you see it on the screen. Essentially, it's claudication. It's lower amount of oxygen going to your feet and your legs. Never a good thing. The indicators are on the screen. None of them are good. If you get to a non-healing ulcer or wound, it's a really, really bad place to be. And we're going to talk about that. Dr. Gitterle is going to have some real-world examples up there, which are I think, pretty impressive. So Dr. G hit it, and it's tough to diagnose on your own, even though if you have these risk factors. One that we left off, and I probably should have added, is obesity. And most of the patients that come in are either obese or morbidly obese, and that does not help the situation. If you smoke, if you have diabetes, it's 4 times the risk factor. Never a good thing. Not only that, but hypertension. All these things add up to not only PAD, and we'll talk about CLI in a moment. I know these are acronyms, but then the risk associated with a cardiovascular event goes up dramatically. Talked about the prevalence and almost 20 million Americans. And then in addition, the asymptomatic situation that Dr. G mentioned earlier is also prevalent. So sadly, PAD is a verifiable predictor of cardiovascular disease, either in the extremities or also cardiac. And you see the risk of a cardiac incident or cardiovascular incident if you have PAD, it goes up dramatically. So CLI is a subset, so to speak, of PAD. When you get to the point of number 4 or number 3, non-healing wounds and gangrene, never a good thing. You want to interject with these patients early and unfortunately sometimes often. And we were asked about, how we, in the space, in the free market medical association space and the alternative payment models, how we will actually handle that in terms of reimbursement. It's going to vary depending on the patient protocol, which we can talk about a little later as well. But also, if you're talking about a specific intervention, like an angiogram or a venogram, right, then it's easy. If you have a patient coming in for multiple wound treatments, it gets a little bit tougher, right? Yep, sure does. We highlighted in the bottom in yellow the risk of amputation, and I know Dr. Gitterle is going to talk about that as well. I do want to emphasize too that none of our employed physicians do amputations. We don't do amputations. We refuse to do them. We will, if we have to, of course. We have a couple surgeons that we can refer to, but Dr. G is going to tell a story about WoundCentrics reducing the prevalence of amputations through second opinions. It's pretty impressive. So, how is CLI determined? Again, claudication, reduction of O2, but then the last two on the screen are serious. And number 5, there's still an avenue for success. Number 6, there is as well, but it just becomes less of a solution at that point. So there's a few different costs here, of course. CLI, if you get to a point of amputation, the financial cost is one, and of course there's a huge savings if you don't amputate. It costs a whole lot less to treat, catch it early, and then assist these patients with their wounds and better blood flow and better oxygenation. Also societal costs. Disability-free years, and then not only that, but of course depression and everything that goes along with it. The next slide talks about mortality, and the 5-year cause of death following amputation can be up to 10 times more than coronary artery disease, which is not to be downplayed at all. Which is why we have such a heavy focus on the reduction and the of amputations and making sure that our patients have an option versus just having your leg amputated. And I often give an example. I know the folks we've talked to over the past couple of days. If my mom or dad saw a surgeon and the surgeon said to my mother, you'll have to have your leg below the knee amputated, my mom would have some grief. She'd probably be a little upset. She would get to a point of acceptance, and then away she goes, right, to the OR. Amputations take about 45 minutes. They pay 4 times to 10 times the amount of a revascularization procedure. Cardiovascular procedure, revascularizing lower limbs, can take 2 to 3 hours. And we do that because, and Dr. G's going to talk about this, to prevent patients from losing their limbs, and some pretty good stories coming up. I'm going to pause there and turn it over to Dr. G, and get ready. This is pretty good.
All right, thank you, Shawn. So, yes, I was a career emergency physician, 22 years, chaired department. Very much enjoyed that, but had a great opportunity back in 2010 for the system I was working for. They wanted to go deeper into end-to-end kind of wound care, comprehensive wound care. And so I jokingly say my wife said yes, because no nights, no weekends. But moreover, it was just a great opportunity in mid-career to get that thing, to do that thing that we rarely get to do, which is really sort of reinvent yourself and see another side of medicine. And I was already sort of a creature of the hospital, I'd always been a hospital-based physician. And so you get a very stilted, kind of aberrant view of medicine that way. And so, my eyes have progressively opened, and over the years, of course, cynicism sets in, and it's happened to all of us, the dark night of the soul. But thanks to Shawn and folks like him, I've been able to, kind of see the light again. And just very much enjoying this movement. So I asked myself, so what can we bring here? Obviously, we're not going to unpack the details of how to deal with, this insidious disease combination, diabetes, vascular disease, in a 30-minute talk. We really can't. But I think there are some salient points that we can make from our perspective. One pearl in this space, I think, that is absolutely key. It's it sounds absurd, but when I teach this, this is the first rule of amputation prevention: don't amputate. It's so simple. So why can't we do that? And that's a great question, and it's a deep question. But we have a special perspective in this movement, so we know how disease processes can get monetized rather than addressed, right? In a perfect world, we'd really be marshaling the best evidence and creating care pathways and, all the cat herding necessary to marshal those resources to take care of those problems. We don't really do that, though. We built a system that monetizes events and monetizes things that we can do to patients rather than outcomes. We all know that, so I won't belabor that. But DFU and CLI are especially susceptible to being monetized like that, a diabetic foot ulcer and critical limb ischemia, because they're inherently a little bit more or a lot more complex. They're variegated in their presentation. So it's harder to bundle them. It's harder to create outcome expectations because of the inherent complexity of the cases. And so that creates kind of an opportunism. Nobody can really point a finger. If we have a high amputation rate, well, the diabetes rate is really high. So we have the highest amputation rate in America in the San Antonio and South Texas region. So in fact, when we piloted, so for many years, I was sort of in this vascular Lonely Hearts Club. I was running this wound care team. We grew to 12 states. 50 hospitals. We do end-to-end wound care. The vision was to unsilo because patients move through all kinds of silos. So why would you just build a shiny outpatient clinic silo or an inpatient silo? You have to unite them. So, but what happened was we really saw uneven outcomes because we didn't have an even playing field for vascular medicine. And that's the linchpin of the most difficult cases we see. And that's one of the reasons that statistics are so up and down with this disease, and why hospitals can tolerate just appalling statistics that would otherwise consider themselves centers of excellence when it comes to amputation. So this is kind of our perspective. So I knew that we had to pilot bringing in vascular medicine to our group, and so we did that 2.5 years ago, and we piloted in the MSA in America with the highest amputation rate, Corpus Christi, Texas. So it's like a 45% diabetes rate there, just shocking. In the rest of the country, it's like 12, 13%. So we picked a difficult spot. So this kind of informs this conversation. And we had, it was very heartening because we showed that we could really change the way that this disease is managed at a fundamental level. Also, I think you guys will appreciate as part of this movement, we did this in a freestanding center. So part of the answer may be, teasing this away from hospitals. But so these are variable cases. They're a lot more susceptible to bad outcomes due to poor concordance. I like that European term rather than compliance. They're complex to manage. So you have to build systems and teams that just embrace that complexity and the long arcs of care. It doesn't mean things have to get more expensive. It just means you have to build your expectations in and train your team to manage patients over that longer arc of care. You can't just do something to somebody and say, good luck. The question comes up, there are very few bundles, if any, related to DFU and CLI, but I think they can be built. And so we're seeing roughly 24,000 encounters a month now as a group, and we've got the data, and I think we can do that. So that's something I'm really excited about doing. Type 2 diabetes is on the rise, so we're going to see it, in this free market, medicine movement. We're going to have to deal with this more and more. And hopefully, as the previous talk was encouraging, I think we can manage diabetes a lot better. But we need to build in the ability to manage these cases. So again, we have a really opportunistic approach, surprise, surprise. But I think if we change our expectations, reward the right outcomes, reward healing rather than amputation, empower direct primary care practices to recognize limb threats early and intervene quickly, embrace the intensive education necessary to manage these cases and the complexity, prioritize early and meaningful vascular evaluation. You would be shocked at how many hospitals that our providers work in where a pre-op vascular workup before, say, a toe amputation, which should be approached with temerity. Toe amputation shouldn't be perfunctory. And the vascular workup is, well, I failed to pulse, it bled when I cut on it. I mean, that is a vascular workup, and that's wrong. That is just wrong. So that needs to change. And I believe that in the future, the way we're going to win this battle on all these complex diseases is a measurevention approach. Not just say, these are all the things you need to do. You need to go back every week and make sure that every patient has received all of the interventions. It's called measurevention, and I think it's going to change a lot of things. And again, a move away from a hospital-centric model. So this has all been abstract up to this point. So what does this actually look like? So this case is kind of a Rosetta Stone to unpack, I think, a lot of what is kind of wrong with how we think about amputation prevention. So this is a 63-year-old patient, uninsured. He had some means, not wealthy, but just uninsured, and he, pre-Medicare age. And so I'm consulted. I see him in the hospital. And he's scheduled for a BKA/AKA. The vascular surgeon that came to tell him he was going to have an amputation didn't even remove the dressing because he was so convinced by the podiatrist who'd been called by the ED that the guy needed an amputation. So I had to do the first step, which is common in these cases, talk them out of an amputation. And what's the point there? Well, we can always amputate later, but we can't unamputate. So how did we go from the picture on the left to the picture on the right? And by the way, he just went on a cruise with his wife last month. He's got a nearly normal gait, very functional foot. So all the things, you can see over there, what did it take? Now, we had to do a lot of things. It cost about, I believe, $43,000. And we were able to contract with him to provide all those services. So debridement, that's a very cost-effective procedure. Anybody can do that, or any wound center can do that. We used a kind of a breakthrough, $30, it's called Revity. It is a cleanser developed for dentistry for root canals, and it eradicates biofilm. I don't want to get into the science here. That's a very important determinant of outcomes and infection in these patients. So for $30, we were able to completely eradicate biofilm on that wound. We were able to, of course, do all the things, culture-directed antibiotics, optimize his glycemic control. We got it very tight. His A1C was in the 6s, protein supplementation. We had to do a course of hyperbaric treatment. He did have one endovascular intervention, and he had a stent placed. And then we used something called Miragen. So very commonly, these patients get monetized by putting a sequence of amniotic grafts on them. And so, it's a multi-$1,000, that's a pretty good sized wound. So, Medicare and most private payers will pay exorbitant prices for paper-thin sheets of amniotic material, and week after week. And so there's the requirement that you're doing comprehensive wound care, and it has to fail. But what ends up happening is you do comprehensive-ish wound care. You check the box, and you don't really marshal the compliance or concordance and do all the things. And then, oh, darn, we failed. We're going to have to, make $5,000 a week, on this patient. So instead, we used something called Miragen, which is an abiologic, and for about $2,000, we were able to apply multiple, I believe it took 3 applications, and you can see the outcomes. So this is just a good example of the complexity of this. We couldn't just do one thing, and it's not just about what you put on the wound or do to the wound. It's a whole patient approach, and it did require vascular intervention. So most programs are not built to manage this kind of complexity. They're built to monetize the most valuable revenue generators. And no wonder there are more amputations. So I want to say that's 5 months. Yeah. So some more examples here. So this is a patient who was told, this is our other, so we've been tracking in the Corpus program, Corpus Christi, all of the patients that are sent in who were told they needed an amputation by a vascular specialist who said nothing could be done. We can't fix your circulation. you're going to have to lose your leg. And so oddly enough, we've been able to not amputate 57 of the 59 so far. So it's starting to look like a pattern. And so this is just an example here of this patient, who is told nothing we can do, and they hear that there's another, place will give them a second opinion. And so what do we do differently? Well, this is another area where this gets into how do we, the industry has effectively monetized and come up with this kind of lowest common denominator, spend the least amount of time in the cath lab, move the patients through, and you cannot do the subtle procedures that are necessary in order to revascularize these patients. So you can see here, this patient, has no significant flow in the superficial femoral artery, severely calcified. It's very time consuming. This takes hours to get through lesions like that. You can't just inflate a balloon. And I've sat with hospital administrators just trying to better understand, how they see the world. And I want to bring some of these providers that can do these things into their facilities, and they will get disenchanted with them very quickly because they tie up those rooms for a few hours. And, but here you go. So, this is standard operating procedure for us. And now you can see it's a superhighway. And so this patient healed up and evidently didn't need an amputation. And again, nothing unusual. Also, you can see, it's one thing to revascularize a segment, so approximately, but is that going to get to the foot? And you can see we have 3 vessel runoff to the foot. So we call this partnership, it's a sister company, Texas Cardiovascular Institute. We've got 2 locations in San Antonio, 1 in Corpus Christi. We're partnered in Lafayette, Louisiana now as well. And again, so this shows the 57 and 59 so-called no option second opinion patients who have been saved. In San Antonio, we're building a surgery center of excellence, 7,000 square feet, 2 ORs, 3 procedure rooms. We want to do hearts, joints, spine, general surgery, and pain. We want to do these bundled and try to shoot for 15% or more below the benchmark. And again, strive for best in class and make this a destination medicine program. It's 15 minutes from the San Antonio airport. So our vision is to take this same philosophy, be subtle, patient responsive, target outcomes and patient satisfaction, and not, just try to monetize, moving the patients through. So I think it can be done. I really think this approach can apply across all specialties if you change your views. So, yeah. So, thank you, and yeah.
Thanks, Dr. G. Very good. Very great. Thank you. The surgery center should be open in June, and we're loading up on Coral and a few other platforms. We have our final state survey on May 18th. Not that it's on my mind or anything, at 1 o'clock with Robert Flown from the state, but yeah. But the really cool thing is that it's a freestanding building in the medical center, and 2/3 of the space of the MOB of the 1-story medical office building is a rectangle is ASC. 1/3 is clinic space, and we will have overnight capability in the ASC. We roll the patient if we need overnight stay across that vestibule from the ASC into the clinic space. We have a nice hospital bed over there. At a very minimum, it'll be 2 nurses to 1 patient. If you have 1 patient in-house, you have to have 2 nurses. And we're not, we aren't doing any cowboy cases. These are our predictable patients that, let's say a total knee comes in and they need an overnight stay. We won't take patients from the ASC that don't meet the setting. We've got some really responsible anesthesiologists. Our surgeons are all top notch, as we know. As Tim talked about earlier, it's all about your brand. And when we're doing something a little bit different, you've got to make sure you've got the best physicians in-house doing the procedures, because really 95% of an outcome in an ASC is in the hands of the surgeon. You name it down, right down to infection. You think it might be air exchanges in the OR. That can happen. for instance, but typically it's protocol and procedure by the surgeon. So a little bit about the ASC, a little bit about WoundCentrics, and I think 50 plus locations right now, and looking to, of course, expand that. But then the office-based labs, Dr. G mentioned we have 4, and right now, plus the ASC. Really, we feel strongly about the base in South Texas, and I think we're just starting to scratch the surface on what might come down from the cardiovascular side, let alone the surgery side. So, are there any questions, Dr. Johnson?
I had a question about those 57 and 59 no option cases. Are there not other vascular surgeons out there that are interested?
Plenty, but so no doubt there are, but the tendency is for kind of in that region. My expectation would be if they sought a second opinion from kind of the standard operators, they'd get the same approach. Nothing can be done because none of them that we're aware of kind of take this painstaking, very small wires, slow procedures, sometimes going antegrade from 2 directions to get those long lesions opened up. Most of our cases involve atherectomies before angioplasty, whereas the other guys are mostly just doing angioplasties and no atherectomies, so that they pay more. 3 times the amount. So we're removing that plaque, before we dilate the balloon. And so you're not just fracturing plaque, and you can almost set a timer. Unfortunately, it seems like sometimes the patient, the revascularization fails before they get to their car in the parking lot. But they still get paid. So I hate to be so cynical about this, but the fires of cynicism have been stoked by years of watching terrible cases that could have been salvaged. So, yeah.
One more thing before we ask that next question. That was a great question, Dr. Johnson. I think one other distinguishing factor between our group and there's 2 major groups in South Texas where these second opinions are coming from. Both groups don't do phanograms because, as Dr. G mentioned, they pay about 1/3 less. Also, they do have employed surgeons on staff that do amputations. Amputations are quick, so to speak, 45 minutes. They pay an exorbitantly amount more than doing a cardiovascular procedure in an outpatient lab. And the real moral issue is both of these practices own their own prosthetics stores, and so you go for your surgical workup, and they say before you leave today, you have surgery on Tuesday. Make sure you go next door and pick up your new leg. By the way, it's the best leg you can get because OIG says I have to tell you we own the store, and so that's just a total conflict of interest that we see as very unethical, and we don't play that game.
Right. Well, and you're referring to an individual patient, like, in other words, yeah. So I think it's a lot of things. First of all, creating that relationship with them. We try not to practice hit and run medicine. We want to, and I've taken care of that same patient again for a more trivial ulcer. But we try to do some things that are known to reduce recurrence long term. The hyperbaric course that he got, creates some neovascularization, and you can really see the long-term difference in his skin perfusion. So yeah, that's a great question though. Like, how do we deal with this as a healthcare system? Because it's like if it's the perfect storm to bankrupt the healthcare system. This confluence of diabetes and vascular disease, it's just immense. So, but I think we can do it. I really think if we're more systematic, I think it can be done. Oh, go ahead. Yes. Absolutely, yes. So so we do 2 weeks a month of training. So I'll be lecturing 16 hours next week, as part of that program. Yes, yep. Internally, right. If you go to woundcareuniversity.com, that's us. So, yeah. Go ahead.
Question about how you solve that problem of incentives systemically.
Mm-hmm.
There's always going to be a motivation to do what pays the best, and there are some people who will make decisions based on morality, but I think it's probably not as much that there are bad surgeons who are just doing what pays them the most money and good surgeons who are just doing what is best for the patient. How do we better align incentives when it comes to getting the right procedure?
It's a good question. I think part of it has to be just on a quality basis. Patients becoming more and more aware that there are groups and centers that amputate less, and and the word gets out, and they have higher expectations because the patients just do not know that patient, when they're told by that vascular surgeon, "Oh, we've got to take your leg tomorrow," who are they to not respond? So it takes some convincing to convince them to give not amputating a chance. Yep.
And how many patients out there, right, that have that level of sophistication and knowledge of how the system works? Right? I mean, very, very few. All of us in the room can probably navigate, right? But we're less than 1% of the population. It's tough. That's a really good point.
Yes. Go ahead.
Yeah, along those lines, what levels of publication and publicity have you done, or are you preparing to do?
We're working on case series. We do RCTs. We are in other areas of vascular medicine right now. We're working on a case series where we've shown that we're early adopters of a device that will evacuate chronic DVTs, and there are many things that have been surprises over the last 10 years or so. One is the high prevalence of May-Thurner syndrome, which is compression of the iliac vein, which creates venous hypertension in the leg. And then the other thing is this recognition that there are lots of chronic DVTs, and if you can evacuate them, venous disease gets better very quickly. So we're writing a case series on that. We're doing a case series of the second opinion amputation preventions too. So we're trying to publish, but yeah, we're having to beef up our data department and contract out for that because it's hard to practice and write at the same time. So, and I did a case series of that. We were the first group to use that debridement agent. It's a dental product, and so as a result of our work, we published a case series. The company is seeking FDA approval to rename it for Wound Care, and that's a disruptive innovation. We've used it to prevent amputations with deeply infected, where there was a large cavity, infected cavity in a foot, and been able to, within days, all the redness is gone, the patient's not septic, and those would have been amputations, the first or second day. So things like that.
Before you just want to say anything, Dr. G, just the attitude. I'm not a clinician, obviously, and if someone knows something with a new product or a new solution, I'm going to Dr. G. I always listen to talk to people and investigate results. So that's pretty good too. I'm pretty cool that no blinders in our company, and folks are open to other solutions, which feels really good.
Regarding the younger physician population embracing this concept and training, do you think there's an external motivator because they're a consumer of this fragmented mess of healthcare? And what are the intrinsic motivators you're seeing as a physician lens through that?
It's a good question, and we do have medical students and residents rotating through some of our centers, and I think just seeing a different model and not seeing like perfunctory amputations and stuff, they don't have a chance to get, inured to it. I think that's what really happens, is they get inured to it and they see a different way. I think the whole healthcare system is just ready to see like a different way of doing it, just like with this whole movement. And it's part of it is just getting out there and doing it. Like when I show some of those, it's just one case, but these cases I like to show like to vascular surgeons and other wound care physicians, and their jaws drop because to us that's routine, and to them it's like wow, So it shouldn't be wow. It should just be like, yeah, that's what we do. Yes. Yes. Oh yeah. Oh, that's absolutely. That's a great. Yes, there are 110 million Americans with periodontal disease. That product that we use on feet is actually FDA approved for periodontal disease, and it could be. Yeah, I mean, it's fantastic. So in an Italian study, it eradicated completely. You couldn't find with DNA probes the pernicious bacteria 2 weeks after a single application. So that means it was really wiped out. And they just put it in the sulcus, wait 30 seconds, rinse out the mouth. That's a disruptive innovation. And I agree, because that causes diabetes, strokes, heart disease. We know that. And so this is another thing. I think the further upstream we get, and in this movement with DPC and informing our DPC folks, they can start doing these disruptive innovations before these patients get to that point. So it's all opportunity, I think. All right, thanks you guys very much. Thank you.